I'm Dr. Michael Quinones, and I'd like to present a webinar on heated intraperitoneal chemotherapy, also known as HIPEC. I'd like to tell you a little bit about myself first. I went to Yale undergraduate where I majored in molecular biophysics and biochemistry. I subsequently went to Harvard Medical School where I graduated, and then went to the Brigham and Women's Hospital at Harvard, where I ended up getting my training in surgery. I did a cancer research fellowship at the Dana-Farber Cancer Institute, and I came here to Decatur in 1994 as a surgical oncologist. About 10 years ago, I started taking up HIPEC in order to afford those patients with carcinomatosis better treatment, and that's what this talk will focus on. The talk will be divided into several portions. There will be an introduction, then I'll get into the rationale, who are the candidates, I'll describe a little bit about the procedure itself, I'll talk about the results and what the future directions are for this technique. I'm going to start off by saying that peritoneal carcinomatosis is uniformly fatal if untreated. There's a 6-month median survival, and chemotherapy by itself and surgery alone really have very limited roles for this. The peritoneal malignancies, or carcinomatosis, really spread by 3 different patterns. It spreads by either direct extension, so the tumor spreads into adjacent organs or directly into the peritoneum. It can exude into the peritoneal fluid and then go to different sites remote from the original tumor in the peritoneal fluid, or surgical trauma itself can spread the tumor. Because there's a volume of disease and a certain amount of tumor present in the peritoneum, cytoreduction, or reducing the total amount of tumor, is always necessary. The chemotherapy itself has limited penetration into the tumor itself, so you do have to reduce the bulk of disease in order to have this heated intraperitoneal chemotherapy really work. When we do the chemotherapy, we use hyperthermia, or a heated nature to it, and the reason is because the hyperthermia affects multiple sites. It affects the cell membrane, helping break them down. It affects the cytoskeletons, or internal skeleton of the cell. It affects macromolecule synthesis, or synthesis of proteins, and it also affects DNA repair. So there's many different ways that the hyperthermia sort of aids in the treatment of these cancers. Then the hyperthermia also makes certain other agents work even better. It was tested against quite a few different drugs, and it's been found that really there are 3 that seem to be the most effective when combined with the hyperthermia, and that is mitomycin C, oxaliplatin, and cisplatin. Mitomycin C and hyperthermia is really what we seem to be using the most, and one of the things that we like about this drug in particular is that it's independent of the cell cycle. In other words, cells go through a certain amount of what we call the cell cycle. Sometimes they're dividing, sometimes they're resting, and certain drugs will affect cells and kill them depending on where they are in that cell cycle. Mitomycin C is independent of that, so therefore it seems to achieve a greater kill across all types of cells, no matter where they are. And it really is at this point the most commonly used agent for pseudomyxoma. The timing of the treatment is also very important. One of the reasons we like this particular technique is because you want to do it when there's the fewest number of adhesions. Adhesions are when the intestine sticks to itself. That's a consequence of doing surgery at any given time. And when you have these adhesions, you create these areas where the chemotherapy otherwise would not penetrate. When you do the HIPEC exactly at the time of surgery, these adhesions have not had time to form, and therefore it is more effectively distributed across the entire abdominal cavity. When we look for those people who are the candidates for this, We want to make sure that they are medically fit, that they don't have any extra abdominal disease. In other words, you don't want patients who have disease in their lungs or brain or other organs outside of the abdominal cavity. The pseudomyxoma, or PC, must be potentially resectable. The surgeon must feel that it really can be removed. There should not be disease directly inside the liver. Parenchymal liver metastases means directly inside the liver. Many times we will remove tumor that's on the surface, but when it's deep inside the liver and we have to remove a large portion of the liver for that, that's a relative contraindication to this. And then patients who have very large, bulky disease really do not fit those that would do well with this surgery. Those patients who have better performance statuses, that's what the ECOG performance status means, seem to do better as well. Patients who have a 0 or 1 have a better survival than those who have a 2 or 3. Basically, if you're able to take care of yourself and you overall are feeling quite well, you fit into the 0 or 1. If you really need a lot of assistance in order to take care of yourself or cannot take care of yourself at all, you start falling into the lower categories. And these correlate quite strongly with how you do with this particular surgery. Patients who have obstructions and ascites or fluid in the abdomen, really, those are relative contraindications to this. We find that patients with very pronounced bowel obstructions generally cannot be resected and is usually associated with big bulky disease. A single obstruction by itself is not a contraindication if you can remove it. But obstructions as a whole seem to be correlated with other aspects that make it not resectable. And malignant ascites is something that we just have to watch very closely. With certain cancer types, the ascites is a relative contraindication itself. However, in the pseudomyxoma, there is mucinous ascites, and we know that that's really part of the disease. So the mucinous ascites by itself is clearly not a contraindication, and it's really something that we find in all of the patients with pseudomyxoma. There's different diseases for which we see carcinomatosis. Colorectal cancer has 130,000 patients per year that have the colorectal cancer, and 12% of those will have carcinomatosis. You see there the statistics for gastric, ovarian, mesothelioma, and appendix. So these are all diseases for which we sometimes will consider doing extra treatment because they have carcinomatosis. And a little later I'll touch on the data as to which ones we actually do it on. I'm going to talk now about the procedure itself. It's very important that you get a complete cytoreduction, that you remove all possible tumor. If you cannot get the tumor out, the procedure itself will not work. This will be combined with peritoneal stripping, taking off the lining of the peritoneum or of the abdomen, removing any portions of bowel or other organs that are involved, and removing the omentum. The omentum is the fatty layer inside the abdomen, and even if it is not obviously involved, it needs to be removed because many times it is a rest for cancer cells of this kind. The original technique as developed by Dr. Paul Sugarbaker was an open technique where the abdomen was open and you put the chemotherapy in and you use your hands in order to push it around. This requires what we call a laminar flow containment or a specialized airflow containment system right over that so that any aerosolized chemotherapy agent is sort of sucked away. Now this, for the most part, requires a research facility, and it was difficult to sort of translate this particular technique into other centers all the way across the country. Because of this, a closed technique was developed, and that's a technique that's used most commonly, where the abdomen is closed after certain tubes are put in, and we end up delivering the chemotherapy. There's no significant exposure to the surrounding personnel. There's some consideration as to whether or not the increased pressures may be beneficial, but for the most part, it's the closed technique that allows this to spread to many centers across the country. The drug given, for the most part, is mitomycin C. We give 30 milligrams in the first hour, and then because of a certain amount of breakdown, we give 10 milligrams for the second hour. The amount of solution that is being used is about 3 liters. Therefore, we are really trying to achieve a concentration of 10 micrograms per milliliter. We keep it at an inflow temperature of 40 to 42.5 degrees Celsius. There's an outflow temperature that needs to be maintained as well. The perfusion is for 2 hours, and at termination of the procedure, we wash everything out with fresh crystalloid or fresh saline. I'm going to show you now a little bit about what the machinery looks like. This is the machine before all the different tubes get sort of hooked up. And this is what the machine looks like once all the various tubing is connected. For the most part, it's a variation of a cardiac bypass machine. It allows the temperature to be regulated. It's very non-traumatic, and it is easy to operate. This is a screen on an actual patient, which shows inflow and outflow temperatures. You can see on the right-hand side where it says 42.5 degrees and 42.2 degrees. This is a demonstration of an actual patient who's getting the chemotherapy itself. At the upper part, to the nurse's right hand, you can see the inflow, and the outflow is a little lower down. The nurse there is currently shaking the patient to make sure that we get optimal mixing of the chemotherapy agent inside the abdomen. We maintain the patient very relaxed. The abdominal wall is lax, so that we allow the chemotherapy to really fill the whole space and reach every little corner to treat properly. This is a flow sheet in this patient, which shows how the temperature is maintained. We also want to maintain the urine output, which is measured very carefully. And we also want to make sure that the patient does not have a very high temperature, which would necessitate the use of cooling blankets or other means to cool the patient down. That's a very rare complication, but it's something you just need to be aware of. As you do the procedure, you then assess for the completeness of the removal. R0 would be a complete resection. R1 has only microscopic margins. 2A is tumor up to 5 millimeters, 2B 20 millimeters, and 2C greater than 20 millimeters. Another way of looking at this is the sugar baker method of a CC1 less than 2.5 millimeters of thickness, 2.5 to 2.5 centimeters, or greater than 2.5 centimeters. Really, it's those patients that have the small volume disease that are the ones that we can treat with this. You want to have basically just a few millimeters of thickness of any tumor left behind, because anything much thicker than that, the chemotherapy will not penetrate. The results show that there's a complication rate or morbidity, depending on the study, between 27 and 56%. The most common ones are listed there. They are abscess, which means infection, fistula or connection to the skin from the intestinal hookup, ileus, which means the bowels are just slow to wake up, pneumonia, which are lung infections, or hematological or bone marrow toxicities. Again, the hematological and bone marrow toxicities are quite uncommon with the mitomycin C. We see a little bit more with some of the other agents, which are absorbed a little bit more readily. The mortality is pretty low. I mean, you have to remember this is still a very big surgery, and it ranges between 0 and 11%, depending on the study. When you look at clinical outcomes, this is the Netherlands phase 3 trial, and it showed an improvement of 3-year survival from 25 to 39%, and the median survival increased from 12.6 to 22.3 months. In this particular study, it was important to have an R0 or R1 resection, and this was the randomized trial that showed that this is extremely effective for colorectal cancer. So this expanded the indication besides pseudomyxoma into the colorectal range. With pseudomyxoma peritonei, the 5-year survivals are between 66 and 97%. Median survivals are between 34 and 67 months, and it pretty much is considered the standard of care for pseudomyxoma. Now, ovarian cancer is much more responsive to systemic chemotherapy or intravenous chemotherapy. So the benefit is really not as clear for this. There have been articles which have looked at delivering intraperitoneal chemotherapy. The New England Journal article was not a heated peritoneal chemotherapy, and there was a delay in giving it because tubes were placed in and it was given after. This was a complex paper and has been under a lot of scrutiny. There have not been good studies looking at, in a randomized manner, heated intraperitoneal chemotherapy with ovarian cancer. We tend to use it more for the mucinous kind because that's really a variation of pseudomyxoma peritonei, and that's probably at this point where it is best used in the ovarian cancer. With gastric cancer, there really is not a very clear benefit with this. There is a lot of carcinomatosis associated with gastric cancer, but the clinical outcomes have really not borne it out. So at this point, when you have a stomach or gastric cancer causing carcinomatosis, the use of HIPEC is really not indicated. So what are the future directions? Currently, it's available in about 25 active centers across the country. Clinical trials are underway. Some of the fundamental questions we are going to try to answer as time goes on is right now we're using 2 hours. We believe that to be a very good duration, but it is possible that you might need to use more time or possibly less time with higher concentrations. So optimal duration, optimal temperature and agents, these are all things for future directions and fundamental questions. And of course, establishing centers of excellence. You really want to have this done in places that have a track record with this, and all the centers that are currently doing them do have good track records with this. Here I've included my contact information. Thank you very much for your kind attention. I would be willing to entertain any questions at this time.